Hello, this is Gary Swan from Healthcare Authority. We'll begin here in just a moment. Okay, we're going to get going here. Again, my name is Gary Swan. I'm from the Healthcare Authority. I'm the lead on APM4. Thank you for joining this webinar. This webinar is going to focus on APM4 overview and give you guys an update on the quality performance reporting for 2017. On the slide that you have in front of you right here, we have put everybody that's listening in mute mode. If you'd like to ask questions throughout this webinar, please input them into the question panel. We'll address them as they come or at kind of appropriate stopping points. So for today, I thought it would be helpful for us to do a complete kind of overview of APM4, the payment methodology, rehash a little bit how that works with the quality improvement model and how you can input your measures into that model, go over our measures and process review for our quality performance reporting and reconciliation, then address some of the common questions and provide some updates on current year reconciliation of the quality performance data, and round out the conversation with open question and answer. So for this next portion here, I'd like to provide a complete overview of alternative payment methodology 4, giving a little bit of financial background and overview, and then go through the quality improvement model. So starting for APM4, we've converted calendar year 2015 to a baseline PMPM rate, and that is your APM4 rate. We've trended that forward by the Medicare Economic Index to current year. That rate you'll carry forward in future years, and we've linked that PMPM rate to quality performance going forward in future years. So for APM4 participants that are able to perform on their quality metrics, will be able to retain the full benefit of the APM4 PMPM rate as converted by that baseline. For those providers that are unable to perform on the quality measures, they will be prospectively adjusted downward in future years. With this payment methodology, if a clinic performs on their measures in subsequent years, you can earn back the full benefit of that converted PMPM rate. As noted on this slide here, this does not waive any federal provisions on your encounter rate. So if your encounter rate goes up over time, we will true you up to what is federally mandated under our regs. You retain the right to opt out of this payment methodology at a time of your choosing. The current flow of payments in dollars from HCA through managed care organizations to providers remains the same. And for this payment methodology for APM4, we are prospectively adjusting based off of your quality performance. So what this really means, and here's a visual that gives kind of an overview of old world versus new world. Essentially, we are moving from an encounter-based system to one where you're able to continue to be rewarded for providing high-value care and replacing potentially billable encounters with quote-unquote non-billable encounters. So when it comes to our reconciliation process, there's two kind of parts to that we've gone over previously. Under an encounter-based system, you receive each of your billable encounters, and we reconcile to those encounters. Under the APM4 payment methodology, we still reconcile to those billable encounters, but we've converted to a per member per month amount, and you're able to retain that benefit for essentially those non-billable encounters by virtue of performing on your quality measures. And those are the same measures that are in the Apple Health contracts for the 1% withhold. Essentially, we are hoping that this will allow providers to focus on team-based care, on care coordination, expand access over time, provides flexibility to bring in new kinds of innovations through telemedicine and other kinds of innovations by virtue of managing your patient population and performing on those measures for the clients that are assigned to you. So for those non-billable encounters and how we establish how you're able to retain that benefit, we've linked that to our quality improvement model. So this is where the performance piece comes into the payment methodology. Each FQHC is compared against their own baseline performance. For the payment methodology, we compare your prior year to the current, to the performance year. So since we launched in 2017, we're comparing 2016 to 2017 and calculating your rate 2018 that'll go into effect 2019. For the quality improvement model, we weight and the improvement score as well as a quality score, recognizing attainment and improvement. So for those that are high performers, you're recognized more for your attainment of that target. For lower performers, you're recognized for your improvement. And again, this is a model that'll carry your baseline and your performance year with you year over year. So you're continually recognized for that attainment and improvement. So this is a model that you've hopefully seen before from some of the emails that I sent out previously. The weights are evenly distributed across the measures. For the medication management measures for asthma and antidepressant, those have been weighted essentially as one measure, so the even weighting is split for the two components of that measure. The targets and the means are Quality Compass 2015 targets and means for HEDIS specifications, NCQA HEDIS for Medicaid managed care. So you're able to put in those yellow columns your prior performance year, so that would be your 2016 performance, and your current performance year, which would be the 2017 performance. And it'll start to spit out what your quality performance is and what your improvement score is. So your quality is based off of getting closer to the target. Your improvement is based off of your marginal improvement from your prior performance year to your current performance year. And for those that are lower on your performance, so you're farther away from the target, there's more weight put on your improvement score. And as you get closer to that target, there's more weight put on your quality score. This is all rolled up to an aggregate or composite quality improvement score that you'll see in the lower right-hand corner. And we weight that to a percentage. So essentially, we take that quality improvement score in terms of total points, if you will, and divide that by 0.2 to get to the percentage that will be applied to that quote-unquote non-billable encounter component. We have an extensive or a full webinar on this quality improvement model linked there below. And I'm happy to discuss directly if you have any questions on the quality improvement model. But I think our intent or our hope is that you'll start to put this model into practice, hopefully going forward in the future, and being able to measure your performance and ID those areas where you're able to improve. Because of the weighting for quality and improvement and the distribution across all of the measures, we've made the targets gradual to hit. So you may have a large child population that makes sense from a business perspective for you to design interventions, or you may have a highly diabetic population that makes sense for you to design interventions. So you can focus on a specific set of population or a specific set of measures that make sense for the populations that you're serving and still win out on this quality improvement model. But as we improve over time, the theory is that you'll be able to focus on those additional measures and reach your performance. So, as I mentioned before, this is a refresher on how the rates are calculated and where your performance kind of comes out in terms of a financial impact. So for the current reporting year, we're in 2018. We're comparing 2016 to 2017. This current year, we're calculating your QIS, so your 2017 compared to 2016 compared to 2017 per that tool that I just showed you. We'll use that to apply essentially that percentage to your non-billable encounters, and that will impact your rate in 2019. I do want to call out here that we've also put in our our MOU with APM4 participants that we're not putting you at more risk than we would have in our managed care organization. So right now, in terms of total dollars for this performance you're reporting, 1% will be essentially at risk for adjustment for 2019 rates. As we dial up with our managed care organization contracts, that will increase over time, as well as your performance expectations. Last thing I'd like to call out here on this slide, we do have a hard timeline for completing reconciliations. It's September 30th of 2018. The reason for that is that it takes time for us to calculate our final rates, to complete things on our end. So if you have any questions, if you have any concerns, our team is willing and able to reach out and provide a lot of TA to folks. And I want to underscore for this as well that with this September 30th date also means reconciling any kind of data issues that you might have. So it's good to back up a little bit on that date and start reaching out now if you have any questions or you think you might have any issues with your data that you'll be delivering for reconciliation. Last thing here is that in terms of the sheer data pieces, we are following current AUP processes. So I'd like to step through our measures process and review. So these are the performance measures that we're including in APM4. As you well know, these are HEDIS measures. HCA can generate the measure rates from measures 5, 6, and 7. We can generate that from administrative claim data. For the performance measures, diabetes care, high blood pressure, and immunization status, we're looking to FQHCs to essentially self-report these measures. I want to underscore here that we are using MCO roster data as the source for generating our cohorts for these measures. So the final rosters should reflect those enrollments and disenrollments per your assignments with managed care organizations. And I do also want to call out here and we'll touch on this again a little bit later, but for the measures 1 through 4, we've established essentially a provisional cohort for these measures. And what that means is that we've run a diagnosis of diabetes, diagnosis of hypertension, for immunization status, run the patient population based off of those patients that are turning 2 within the performance year to get a first cut of what we think the patient population could look like. So it's on FQHC participants to go back and reconcile those data to fully determine whether or not those cohorts are accurate and whether or not they fall into the denominator for each of those measures. Again, these are Medicaid managed care client patients only. We are applying a continuous assignment and continuous enrollment for 11 of 12 months. So if a client was assigned to you for 11 of 12 months and they were a Medicaid managed care enrollee for 11 of 12 months, then they're attributed to you through this methodology. Additionally, again, we run those HEDIS specifications to get to our measured cohorts for each of the patient populations. And again, we do this kind of provisional cohort for the self-report measures. So the actual number of patients that qualify may be less than the number presented by HCA. So you've seen this slide before, but I want to call it out again. For the current reporting year, we started the payment methodology late in mid-year 2017. We're holding FQHCs, participating FQHCs accountable for the entire performance year. So we, Azure didn't have the data and weren't able to identify registries or do some engagements with these patient populations that you're being held accountable for. We looked essentially to self-report by and large for 2016 compared to 2017. So for those clients that on the bottom 2 boxes, you either weren't able to engage to determine their performance or to determine what their health status was, or those patients that ostensibly aren't your patients, we have dropped those from the performance year reporting for 2016 compared to 2017. So we are looking essentially for those patients that, one, you're saying that don't actually qualify for that measure, either do qualify for that measure, but care wasn't delivered according to HEDIS specifications, or care was delivered for according to HEDIS specifications and they qualify for that measure. So we have a question: are we able to remove patients from both FQHC self-reported as
well as claims-based lists, which our EMR shows are not our patients or do not have diagnosis?
So we'll get to this a little bit later in the presentation when we go to common questions. And if there's additional questions, then you can reach out. So for our performance reporting, and this is a restatement of what I've stated already, but we're comparing 2016 and 2017 purely self-reported. So if you were looking to those self-report measures, and if you're saying that that patient is not my patient, or I don't have any information on that patient, But the patient didn't qualify for the denominator. We're removing them from your performance for 2016 and 2017. So this is basically a cut of patients that you are managing actively. For 2017 and beyond, as outlined in our MOU, we are looking to the managed care reported rosters essentially as a source of truth. So for this year, we will drop out those clients that are zero denominator to compare to 2016, but we will also reset your baseline to account for all of those clients that are zero denominator to compare to 2018 and beyond, looking to your managed care rosters. Really the expectation here is that with more timely data as we ramp up our processes and through the financial data that comes to your organization through the reported rosters, that you're working those rosters and either reassigning clients or patients as necessary, that they are not your client, or actively engaging with that client through the information that we're providing to get them engaged in care. So there'll be two essentially reported rates, one to compare to 2016 and one resetting your baseline based off of managed care rosters to compare to 2018 performance and beyond. So this slide goes over kind of the reconciliation process and the options that we provided in 2016 and restating that for 2017 performance. And essentially, those clients that would not fall into the measure, you're not able to report out whether they fall into the measure for both the self-report measures, so those diabetes measures, hypertension, and immunization. We're requiring SQHCs to report on, but giving the option to SQHCs to report out on the administrative measures. So if you reconcile the administrative measures last year and you'd like to do so again this year, we will accept your data for performance on those claims-based measures that we sent you if you have questions or issues with those data. So I'm going to jump into common questions and updates. This is to highlight we were delayed in providing accurate information to APM4 participants by 2 weeks. So the first set of data that we released, we had to provide an update of the year of analysis for the applying the HEDIS specifications. So we provided an updated data set on August 14th to APM4 participants. Due to that, we've extended the due date for the quality performance data by 2 weeks. So your new due date for delivery and reconciliation of the quality performance data is October 12th, 2018. I want to underscore here also, if you haven't received this updated data set, please reach out as soon as possible to me, and I will make sure that you get your updated data set for reconciliation. In the emails that I've sent out, so we've run into data security questions on our side, and we're wanting to make sure that we are sticking as closely as possible to the DSA. So we're asking that if you have individual questions or you have individual issues on the clients that are patients that are reported out and the HCA provided data set, so whether or not a patient falls into your performance or if there's specific questions or issues related to those data, we're taking those questions and those issues offline and handling them directly with APM4 participants. To To help facilitate this, we've established office hours. So we blocked out time on our calendars with our team here at HCA to address your questions and to provide technical assistance for APM4 participants that are trying to reconcile this information. So Tuesdays and Wednesdays from 12 to 1, we blocked our calendars. You can book this time just minutes in advance or during the hour, however you'd like to kind of approach. But we have that time available for you to reach out directly with your questions and jump on the phone or launch a quick go-to meeting or something to make sure that we're able to walk through some of those issues. So we're asking that you please do not include any comments in the data fields and that you're only reporting the numerator denominator. And a highlight for the self-report measures, I believe that there is not a column header for numerator and denominator. Please add those as you go through and reconcile the information. So I'm going to go through some of the common questions that we had. We had a question regarding our 2016 data. We finalized our 2016 rates, but we do recognize that there are maybe specific questions or issues. Please reach out to us directly if you have any questions or issues with your 2016 performance, and we will follow up directly as appropriate or necessary to make sure that we're resolving those issues or those questions. Had a question about our measure specifications. So we are applying the HEDIS specifications for each of the measures. We've put in the sheet that HCA sent out essentially the provisions by which we've developed each of the measures. So in that header block, it shows how we generated the measure, what criteria we applied, and what parameters were put on place to get to that cohort, whether it was administrative data to show how we established the final count cohort or the provisional cohort on those self-report measures. For the specific information on the diagnoses or how the measure is applied, you have to reach out and get the HEDIS specification information as it's proprietary information, and we cannot actually provide that from healthcare authority. We had questions regarding the timeframes for the data. So your prior performance year data is 2016. We reconciled that in 2017. So 1/1/2016 to 12/31/2016. Your performance period for the data that we're reconciling currently is 1/1/2017 through 12/31/2017. Just in general, there's questions on what the ask is of APM4 participants with the spreadsheet that we've provided, and what the expectations are on reporting back to HCA. So we've provided updated data from the past year that includes additional demographic information. The most ideal marker for you as a provider to grab those clients is MMS ID, but to help you increase your accuracy and make sure that if you are not collecting those data currently, that we're providing with additional information to identify those clients. So it included some demographic information so that you can better match the patient population. And we've also provided for that performance period, so it would be in 2017, the most recent plan and their plan ID for that performance period. So that would be in 2017. we're asking you, again, to reconcile those data and report back numerator and denominator. Again, those data have been run based off of the reported Medicaid managed care rosters for continuous assignment and continuous enrollment for 11 of 12 months, and the HEDA specifications. For discrepancies, we're asking again that you only report that numerator and denominator, and add a column for those measures that already do not have a numerator and denominator. And then again, lastly, for those administrative measures, it's an option for your organization to reconcile that information, and we'll go from there. So this is a question that we received a couple of different times from a couple of different providers. If the patient is showing in your records as no diagnosis to appearing to have qualified for the measure, we're asking that you exclude them from the final reporting. So you would remove them from the denominator, and we would accept your data for performance. I do, again, want to call out here that for 2016-2017, we're going to remove essentially all of the zero denominators for that measure. But for 2017 and beyond, we're only going to remove those zero denominators if the patient does not fall into the measure rate. Going forward, we'll provide that reset for 2017 baseline to compare to 2018 and beyond. This is a bit of a rehash from the previous question. And essentially, if the client, how you're handling the patients that are, we believe are not our patients. For this year, we're looking to those clients that you're saying that are your patients. Going forward, the expectation is that you're going to be working with your managed care organizations to properly get those patients reassigned, or get that patient engaged in your clinic for care. If your managed care organization is not being responsive to requests, please let us know. We have active channels with our managed care organization to help you resolve issues. And if you have ongoing issues, please reach out and let us know so that we can work with you to resolve issues. We've received a question regarding HbA1c pore control. So if you go to the quality improvement model, the tool that we sent out, the way that it's structured is for increasing rates. So we do 1 minus that measure rate. So when you import into that tool your measure rate, you'll need to invert that rate. For the data that we are asking you to report to HCA, we're actually asking you to report pore control. So we're asking you to not invert that rate through our data reconciliation process, only invert it when you put it into that tool. Essentially, instead of reporting poor control, you'll input good control. If you have any questions, or if you, in the previous reporting period for 2016, had inverted that rate for us, please let us know so that we can make sure that when we calculate your rates that we are calculating the correct rate. If you have any questions, please reach out. We're happy to address those questions or issues. So we received a question we're looking to only those data elements essentially that HCA has reported. In 2016, we look to those essentially those empaneled clients, those clients saying that you manage. And it may differ from the clients that we had sent to you based off of what we're seeing in reported rosters. We're willing to accept that data again this year, and we're asking you to include those patients, but please don't include any additional data elements beyond what we've reported out to you in the spreadsheet that we've delivered. Those data, so when we calculate the final rates and report back out those final rates based off of our data security requirements, you may not see those clients that you reported, those patients you reported to us back in that data file. But please report that information to us. So those are the questions that we've received and received kind of numerous questions on that. In this presentation, I also included an appendix. It includes information from a webinar that we held last year that goes over numerator, denominator specifications for each of the measures. Again, reiterates how we calculated those rates. And again, that information is included at in the header of the data file that we provided to you. So I'll pause here for a little bit and see if there are any additional questions on the data reconciliation process or anything else that I've outlined here today. Again, happy to jump on the phone or use one of our office hours to address questions directly with each of the providers. So we have a question asking about the timeline for when we're going to exclude, how long you can exclude those clients that have been engaged. So the data that we provided to you is for 2017 data. Last year we provided 2016 data. Those data and how we compare the 2016 to 2017, we will exclude all of those non-engaged clients. Or those clients that say, or patients that you say are not yours. We are also this year, to make sure that we are comparing apples to apples, in future years, going to reset your baseline. So for 2017 and 2018 and beyond, this year we're going to reset that baseline to the Medicaid managed care rosters as well. So those zero denominators that we've reported to you, and you're saying that either you haven't engaged that client or you're saying the client or the patient isn't yours, we will count those patients in your denominator in the reset baseline for 2017 to compare to 2018 and beyond. And again, this is to get at the point to ensure that we are engaging those clients or getting them reassigned to the appropriate clinic if they are not your patients. So I have a question, since there was a data revision this year, how do we know we are working with the most current data? And is there a delineation of this in the spreadsheet? There isn't an outright delineation of this in the spreadsheet. How you will know is from the HEDIS specification. So essentially, there will be clients that will have aged out of the performance measure for 2017. Additionally, I believe that we provided in that updated spreadsheet an updated date on the name of the file. If you have a question on that spreadsheet, specifically, reach out and we can follow up directly. So I guess, folks, just a few more minutes if you're typing in a question. The last thing I would add on the revised spreadsheet, the patient population, by and large, should be fairly consistent. I think the biggest measure that would be impacted would be childhood immunization status as it goes to age 2. But for the patient population, for the other measures, it's a larger age range. So I think that you'd see potentially less turnover in those measures. So if you, in theory, have been working with the previous data file, could do a quick check to see if what the difference is in the patient population between those two files, so that you're not duplicating work that's already been completed. So seeing no additional questions, I'd like to thank you for your participation today. This webinar was recorded, so if you'd like to revisit this webinar, or if you would like to pass it along to some of your colleagues or others that were unable to participate, it will be posted following as soon as possible. And again, if you have questions, please make sure to reach out to me. That is my email and my office phone, and we'll have